All right, everybody, it's 8:01, so we'll go ahead and get started. Welcome to this month's AO Spine Fellows webinar. We're going to be talking about degenerative spondylolisthesis. My name is Jason Savage from the Cleveland Clinic, and I have the pleasure and honor of moderating this session with two of my most esteemed colleagues and best friends, who I'll introduce in a second here. So just a couple announcements before we really kind of get into it. First and foremost, thanks to everyone obviously at the AO for sponsoring these events, these educational events, and more importantly, their continued support of all of our fellowships. We have 6 fellows at the Cleveland Clinic, and we are very, very, very proud and honored that we are part of the AO Spine fellowship kind of network and program. So thanks to everybody for that. Just a couple kind of intro slides before we really get into it. So obviously that's me. I have pictures from a while ago. I've been in Cleveland for about 7 or 8 years now. I did my orthopedic spine fellowship at the University of Wisconsin. Worked in Chicago for a little bit, Northwestern, and now I've been in Cleveland, which is now home. So we have an outstanding kind of faculty tonight. We have Don Pelly, who's my associate program director for the fellowship at the Cleveland Clinic, and Dave Casper, who's the co-fellowship director at the University of Pennsylvania. Both of these guys were spine surgery fellows at the Cleveland Clinic, so the AO Spine fellows, and have gone on to do amazing things. And I'm very, very proud to kind of share the stage with these guys. I respect these guys. I trust these guys. I would send any of my family members to these guys, and they're two of my best friends. So thank you guys for doing this. We're going to try to make this as obviously as interactive as we can, even though it is on Zoom and we can't see you all. But I really encourage you to use the Q&A. So if you want to type in a question or have a comment, please use that function. There's no silly question. There's no silly comment. We're going to run this basically like a kind of a case conference, an indications conference. We do that a lot at the Cleveland Clinic. I know Dave does that at the University of Pennsylvania, and I think it's kind of, the most fun. And also, I think a lot of times we learn the most from each other just by talking about cases. So as you guys know, the AO Spine puts on webinars every month for the fellows. Just some upcoming dates here. They're the Tuesday. It's always on a Tuesday night, and it always starts at 8 p.m. Some upcoming webinar topics. Wednesday, is that Tuesday or Wednesday? I thought they were Tuesdays, but there's going to be one on postoperative infection and discitis and osteomyelitis, and then there's one on complications and legal ramifications in spine surgery. So those two will be great, and you will get emails about them. So just keep an eye out for your email. This is just a content validation statement. Basically, AO North America is an independent nonprofit surgical specialty society dedicated to improving the care of patients with musculoskeletal injuries. Does not endorse nor promote the use of any products or service of commercial entities. And equipment used in this course is demonstration teaching purposes with the intent to enhance learning experience. The other thing too, which everyone on this call knows, is that obviously we're going to be talking about today and kind of our opinions are the opinions of they're ours. They're not of the AO. So I'll just kind of throw that out there for disclosure. Zoom etiquette, with COVID and the pandemic, I think we're all very comfortable with Zoom, but all your microphones have been muted. Unfortunately, in the video cameras are turned off, so we can't see you, but we can answer your questions and look at your comments through the Q&A box. So we'll keep an eye on those. So just a really kind of brief 30,000-foot overview. This webinar is really going to be a case-based discussion on the treatment of degenerative spondylolisthesis, and we're really going to focus on, kind of important factors in surgical decision-making. And the learning objectives are relatively straightforward, right? We're going to talk about mostly the operative treatment, but also some of the non-operative treatment options for this patient population. And then more importantly, through the cases, really debate when, why, how, a fusion should be performed, if it should be performed, how it should be performed, and in the setting of various kind of, cases of degenerative spondylolisthesis. So, just as an introduction before we get into the cases, and again, all the fellows I think on this call are very well aware of this. We actually purposely chose this topic because it's relatively, well, we think it's relatively straightforward, but I think after this you're going to realize that it's really not, right? It's one of the most common things that we take care of as spine care providers, as spine surgeons, But it always amazes me if you go to a national meeting, Lumbar Spine Research Society, SRS, AANS, whatever it may be, NAS, you can probably talk 3 or 4 days on degenerative spondylolisthesis, and there's going to be a lot of different opinions in terms of kind of how people manage this problem, which is why I think it's kind of interesting, which is why we chose this topic. It is a common problem. You know, it happens in about 10% of women over the age of 50, a little bit less commonly in men. Just because you have a spondy doesn't mean you have symptoms from the spondy, and we'll get into that a little bit, but it is a really common problem. Obviously, the non-operative care of these patients, like every other spine patient, includes, you know, a focused PT program, core strengthening, weight loss programs, non-steroidal anti-inflammatories, potentially some injections, and et cetera, you know, et cetera. I think there is a role of decompression alone, obviously, in this patient population, and we're going to go over a few cases where we're going to kind of debate that and go over some of the data. I think the literature at this point in 2023 would suggest that decompression infusion for a spondylolisthesis provides, and I put quote, better long-term outcomes. We're going to kind of debate that and argue that a little bit, but I'm going to show one paper, but I do think that, I think we'd all agree, if you have an unstable spondylolisthesis with neurologic symptoms, you know, in patients who have failed non-operative care, I think a decompression and fusion is the right answer for them. The million-dollar question is what about the stable, right, quote unquote, stable spondylolisthesis? Is that patient better off with a decompression alone versus a decompression fusion? We're gonna kind of go into that. And I think also, you know, in this day of age, we all understand that alignment is really important. So even though this is not a deformity talk or deformity presentation, I think it's really important. If you're going to do a fusion on someone, if you're going to put screws in someone, if you're going to put a cage in someone, you really have to focus and do a good job and make sure that their alignment, at least their segmental alignment at that level, is done well. So this is Sig Bervin. I'm sure most of the people on this call know Sig. Sig's a great guy, really thought leader in our field. He kind of gave a webinar, I think this is about a year ago now, and the title was, "If this lumbar degenerative spondylolisthesis case is so straightforward, why can we not agree?" And that's honestly really the kind of the purpose of this kind of, you know, webinar, is to just kind of go over all the potential options that we have at our disposal, and kind of maybe argue a little bit about why we think maybe one is better than another in a certain circumstance. So this is the only study I'm going to show, I promise you. So really, after this, we're going to get into the cases. You know, this is a great study. This is Ogogowala's study that was published in 2016. It's a relatively small sample size of 66 patients, but this is a randomized controlled trial of patients with they defined as stable degenerative spondylolisthesis. So this is kind of that patient population that I think we really are trying to kind of figure out. You know, the unstable patient populations, the ones with mobile spondies, I think all of us would agree that a decompression fusion, some type of fusion is the best option rather than decompression alone. But the stable spondies, we kind of, I think, always scratch our heads and say, gosh, I hope we're doing the right thing for this patient. This study would suggest that a decompression infusion does provide, you know, quote unquote, better outcomes in that stable degenerative spondylolisthesis patient population. They did a decompression alone versus a posterolateral fusion with iliac crest bone graft. The fusion group had more improvement in SF36 and in ODI. There was no difference in back pain. We'll kind of talk a little bit about back pain throughout this webinar and whether or not that changes your opinion on what you do. But no difference in back pain, whether or not you had a decompression alone or the fusion. But the decompression group definitely had a higher rate of reoperation rate at that index level of 34% versus 14%. So again, this is just one study, but it is a good study that I think suggests that in these patients who have a quote unquote stable degenerative spondylolisthesis, you know, maybe a fusion offers them a better longer term outcome. So with that said, we're going to get into the cases, and then I'm going to kind of hand it over to my two smarter colleagues here to kind of start talking about what they think about this. So this is someone I saw probably about 8 months ago, and he's a 67-year-old guy. He actually works at the Cleveland Clinic. He's a PhD, some sort of PhD, like radiology person. And he's got bilateral leg pain, kind of equal buttock, posterior thigh, and kind of down into the calf. He's kind of got classic neurogenic claudication symptoms where, you know, it's worse standing and improves with sitting. This is AP X-ray, which I would kind of argue probably doesn't look too impressive to most people. And then these are his kind of, you know, bending X-rays. In the middle, it's his standing lateral, and then obviously you get your flexion and extension views. His MRI is here. So now you've got a guy who's got pretty significant lateral recess stenosis at L405. If you look at his MRI, you can almost argue that he doesn't have a spondy, right? But I think on his FlexX films, you can see that he does move a little bit. Let's call it, 2, 3, 4 millimeters. And he doesn't really have any significant foraminal stenosis. So the questions I have for my friends and my esteemed colleagues, and obviously I would kind of ask the participants to, ask questions or kind of give their thoughts of what they would do in this case is, so what are the treatment options, kind of when you go through this case, and we're going to assume that they've, failed non-operative care for the purposes of this talk. What are the goals of surgery, and then maybe some kind of important things to consider when you're approaching this patient. So, Dom, you've been out in practice just a couple of years longer than Dave, so I'll start with you and then we'll hand it over to Dave.
Yeah. So, there's a slip at 4.5. I would argue that, albeit not a high grade slip on the standing film, certainly worse on the standing films than his recumbent films or his extension or his recumbent MRI or his extension film. So the first thing I think we got to decide is whether or not we need to fuse him, right? So when you're thinking about what you're going to do for this, you got a spondy decompression alone versus some sort of arthrodesis, and we could talk about different arthrodesis options. So in my hands, with somebody with a mobile spondy, even if it's a, kind of a slight grade 1 spondy, I would favor an arthrodesis for him. And so the question then becomes is which arthrodesis is best? As you know, I sort of do everything, posterior lateral fusion to anterior to psoas fusion to A-lifts to T-lifts, MIS T-lifts, et cetera, et cetera. I do some more than others, but I favor sort of all of them for specific indications. He's got a fair bit of leg pain. He's got a fair bit of central stenosis. It does not look bony. I think you could do a posterior lateral fusion. I think you could do a lateral fusion or a T-lift are all fine. In my hands, personally, I would probably, if he had the appropriate anatomy for it, do a lateral fusion here, because I think given his only slight spondy and his good bone quality, I probably can get away with supplemental lateral fixation as opposed to doing anything in the back. So that'd be the only reason I would favor that approach. I think that his stenosis is not so bad that I wouldn't be able to sort of help with that. So those are, treatment options. I think fusion or decompression, goals of surgery, fixes leg pain. And the important things to consider here are, which way to do it and why. And in my hands for this guy, he'd probably be a lateral if his anatomy was favorable.
All right, before Dave, before I ask you your thoughts, Dom, I think you bring up a lot of really good points. Question for you, because I don't do nearly as many kind of, laterals as you do, as you know, obviously, but and kind of indirect decompression. So talk me through a little bit about kind of what you're looking at on the MRI or CT or whatever that you kind of say, hey, you know what, I'm comfortable getting an indirect decompression through kind of a lateral approach for degenerative spondy.
Yeah, sure. So first off, I don't really look at the degree of compression. Like I don't say, okay, this is mild stenosis versus severe stenosis. I think you could do some indirect decompressions in severe stenosis if you have some good reasons why. Things that I look for imaging wise, if it is ossification that's causing stenosis, such as an ossified ligament, you're not going to stretch out an ossified ligament. I think there's some good data that residual lateral recess stenosis from ossified ligament does not do well with an indirect decompression. So the things that I look for with indirect are their symptoms mechanical in nature. So somebody that it's got a searing radiculopathy when they get up and they try to walk, and then they sit down and most of their pain goes away, tells me that in some way their pain is a positional problem, right? It's not just a complete compression problem. Like this guy, I would suggest that he probably has something along those lines, because he lays down and he's reduced and he stands up and he gets worse, right? So if they have positional complaints with their neurological symptoms, I think that's a good candidate for indirect decompression. If they have a disc that I can expand, right? So if this guy had this huge, like a huge fish mouth disc that, like, if I did a T-lift, I would struggle getting a good fit with a T-lift cage. Sometimes they're not the best for indirect decompressions because there's not a lot of expansion that's going to occur. I think when you're doing that, you have to be careful about where you put your cage. So you're going to want to bias that a little bit more posterior so you can open up that posterior dorsal space. So I look at, how collapsed is the disc? How mechanical are their symptoms? What is the cause of their stenosis? So this guy, he's got, fluid in his facets that's kind of bulging out. The SAP, he's got hypertrophied ligament and a disc bulge. right? It looks like that'll probably stretch out. And that's kind of my algorithm for when or not I think I'll be able to indirectly decompress them.
Dave, thoughts? And any different thoughts? What would you kind of think about or do in a case
Yeah,
like
no,
this?
I definitely echo Dom's comments. The big thing is I look for indirect decompression are disc height. Someone that has a really well preserved disc height, I worry about the degree to which I'm going to be able to open them up posteriorly. So exactly what Dom mentioned, and then instability. So if someone really doesn't have much instability and a big disc height, I worry about indirect decompression. But if they're fairly unstable or have a fairly collapsed disc, I'm fairly confident I can open that back up. I think this is a great case because this is a case that everybody's going to see when they get out into practice, and they're going to see it a lot. And I think the most important thing for this patient, especially when you start practice, is you get them on and off the table and you get your goals of surgery accomplished.
Mhm.
So what does that mean? It means you get them adequately decompressed. And I agree in this patient, I'd be worried about taking away more of their posterior structures without supplementing it with fixation. So I think, certainly someone that I would offer a surgery in terms of a fusion to. But I think, again, if you get proficient at a posterior lateral fusion and you start off in practice and that takes you 3 hours and you're going to get those nerve roots cleaned out, you're going to get them on and off the table, that patient's going to love you.
Mhm.
And God forbid they have a pseudoarthrosis or they have adjacent segment disease down the road. You've established a good rapport with them. They've grown to like you. You followed them. You really helped them out. So that's something you can explain. I think in my hands, I think this truly is a patient that you can kind of do anything with. I think T-lift's reasonable, MIS T-lift's reasonable. I do more A-lifts than laterals at 4.5, but I'll tell you, low riding crest, certainly amenable to a lateral at 4.5. I haven't done a lot of standalone work from a lateral based approach. I think it's reasonable for certain patients. I probably throw a little bit of caution in there for doing that during board collection. Not that it's the wrong answer; it might just draw a little bit more attention.
Mhm.
But really, I think anything's suitable for this patient as long as you're accomplishing the goals of surgery. If he comes in and says, "Boy, I want something MIS," and you've only done a few MIS T lifts in practice, and you take 6 hours doing it, and he's not well decompressed, he's not a patient that's going to be a fan of yours. So, I think goal number one is make sure you get the nerve roots decompressed, and then goal number two is try and set the patient up for as long-term success as possible.
Yeah, so for everyone in the call, I mean, I think both Dom and Dave hit on some super high yield points, and we're going to come back to this, I think, pretty much with every case. And we're all not that far out in the practice, right? I mean, I'm 10 years in, I think Dom's 7 years in, I think Dave's 3 years in, right? So we remember what it's like to be in your first year of practice, at the end of the day, you want to do what's kind of right for that specific patient and what's best in your hands, right? And that's going to be different for everybody. It's different for the three of us on this call. I promise you that, and so and Dave brought up boards a couple of times, which I think is great because you guys are going to be thinking about that stuff in the relatively near future. And you just have to have a logical reason of why you did what you did, right? So I mean, I agree, Dave, and Don, for this case, I do think that he's got a mobile spondylolisthesis, and actually we could talk about flex X films. It's interesting because I actually very rarely get flexion extension films. I usually just look at the supine MRI and compare that to the upright x-ray, which is basically a dynamic film, right? But, I do think that this is mobile. I think most people would kind of suggest and argue that, yeah, an arthrodesis with a decompression is a good option for this person. But how you do that arthrodesis is kind of really debatable, right? And I don't think there's any data to support one way over the other, including MIS. I really don't. I think, like Dave said, every person you see, if you kind of say, what are the goals of this operation, and you achieve the goals of that operation and you do it well, you're gonna be really happy. More importantly, your patients are going to be really happy, right? But on boards, it's interesting because I'll show you what I did. So just to kind of wrap things up a little bit on this case. So I went what I'd call old school. So the way I kind of thought through this case was, well, you got a guy with I think mobile spondylolisthesis. He's got severe stenosis. He's got leg pain. He didn't have foraminal stenosis. I think severe foraminal stenosis changes things in my mind. I'm not a big fan of a push lateral fusion alone. If he's got severe foraminal stenosis, I think you need to do more to decompress that foramen. And then it opens up all the options, right? ALIF, lateral, TLIF. But without significant foraminal stenosis, you can do this in a very, very less invasive way, relatively quickly. These patients do really well if you get them to heal. I try to do a really good facet fusion. I just drill out the facets, drill out the pars, drill out the medial TPs. And these people tend to fuse really well. Actually, I would argue in my patients, it probably fuses better than a TLIF, honestly. I put this in there because, it's kind of like what I'd call old school, right? It's not very sexy, but it's a really good option, and if you're on your boards and you do this, it's going to be pretty smooth sailing, I think. They may ask you, well, why didn't you do interbody fusion? Well, I didn't think I needed to do interbody fusion because there wasn't, foraminal stenosis, and I thought I can get a good push lateral fusion. And I was a little worried, you could use cost consciousness about the price of the cage and all. I mean, you can go through that. If you do a lateral in this person in your board collection period, it is 100% justifiable. But they're going to ask you, well, why did you do a lateral here? Why didn't you just do a push lateral? So those are the things that you got to just kind of start thinking about when you get early into practice, and just have a good reason for why you did that. And that reason can't be, and these guys are going to chuckle when I say this, but you can't be, well, I'm a lateral guy or girl, right? It's because I'm an ALIF sort of person, or like I like doing perk screws. That's not your answer, right? It's got to be a really good thought out reason, like why you did that for that particular case. So
I would
one thing too, like we could talk about this is like, what defines instability, right? In a degenerative spondylolisthesis. I don't think we really know the answer to that, honestly, right? I mean, there's some papers that say that if there's more than 2 to 3 millimeters of motion on on upright films, if there's more than 10 degrees of angular motion on flexion extension, if you got really kind of sagittally oriented facets, you're at slightly increased risk, right? But the interesting thing about instability in degen spondies in my mind is that you're talking about the stability before you put them through surgery, right? So we don't know what happens, right? If after you do a decompression, particularly if you're going to do an open decompression on someone, how much bone do you have to take away to do that decompression, and will that become unstable? I think these are all things that we still really just don't know the answer to. So I don't know. But before we go to the next case, any questions from the crowd? And you could definitely write too. Hey, I would do a push lateral fusion here, or I would do a TLIF here, or I would do an MIS TLIF here. We want you guys to try to be engaged as you can, even though it's obviously over Zoom. So
Jay, can I say a couple of things about this case?
Please, yeah.
Yeah, so I want to echo some of your comments just because I think they're so important. I want to state them twice. Resist the urge to be a guy that does something in particular, because we see it all the time. You start becoming a hammer and everything starts looking like a nail to you. So I just really kind of wanted to echo that comment. Resist the urge to be a lateral guy, resist the urge to be a deformity guy, just resist the urge to be any sort of specific guy or gal. The other thing I'll say too is I also want to say I think my posterior lateral patients are kind of happier than my TLIF patients. I think it's a better operation if you don't have to really decompress foramen. It's half the time, it's an hour and a half surgery, and I think that matters. I think a small incision, it's not that much bigger than a Lamy. And if you freehand the screws and you focus on your fusion on the facet, kind of like you do, kind of like you taught me, truthfully, they're just happy patients. So I just wanted to echo those.
No, comments. Thanks, Tom. Yeah, and I think the other thing too, I'll say, and again, I figured this would happen, and I hope this is good for the people who are tuning in, is that, don't let like practice type, don't let marketing, don't let like pressure, kind of, change what you do, particularly early in practice, and because you really, the only thing that patient cares about, right? If this was your mom or your sister or your brother, right? The only thing they care about is having a good decompression and get their legs feeling better. And if you are going to fuse them, to have that well done and safely done, right? And in a relatively timely manner, right? I mean, like I wouldn't want my brother having a 4.5 hour lateral because the person's never done a lateral, right? And so just kind of really just if you always remember that, and it doesn't mean that we shouldn't push to a new technique or push technology. And we're going to get Dom. I'm going to have Dom talk about that in a little bit here when he gets to his case, like how he's transitioned to doing a lot more lateral. That's important for us in our field and our patients. But just always remember, just do what you're good at, because I think your patients are going to be really happy that way. So,
hey Jay, we got 2 questions.
Oh yeah, perfect.
So first question is the role of screws based on historical literature
Mhm.
is that question. And then why don't we answer that? Because the second one's a little longer. I got to read it.
Yeah, so I'll take a shot at that, and you guys can kind of chime in. So I think that's a great question, because if you look at the initial data on decompression versus decompression fusion, which is the Harry Herkowitz data and the Jeff Fishgren data, it's kind of interesting, right? Because they basically initially kind of showed that there was really no difference between they showed a difference between decompression and fusion, but then they didn't show a difference between the patients who actually fused and didn't fuse, right? Which didn't kind of make any sense. But if you follow those patients out longer, they showed that the patients who actually fused did better long term. And I think all of us would agree that instrumentation improves fusion rates. So you can then kind of extrapolate that if we're kind of trying to get a solid fusion, instrumentation is going to help us achieve that solid fusion. And then that will kind of in turn lead to better long-term outcomes. But I think it's a great question, because the historical data is kind of, I think it's kind of interesting. I think there's a lot of newer data now, the Zogo study, and there's actually another study that was recently published, really kind of looking at this in a little bit better of a way. So Dave or Dom, do you have any other thoughts on that? Or
No, I agree completely.
okay.
Yeah. So the next,
Okay.
there's two more quick ones. Can you clarify why you did not put in an inner body for increased point of fusion?
Yeah, that's a great question. So I'm not sure if the literature really shows that an interbody fusion or a TLIF is better than a well-done push-lateral fusion. I may be I may get something thrown at me here, but I really don't. I don't think the literature really supports that. I do think that if you do a TLIF really well, you can get a TLIF to heal. I think a TLIF is a hard operation to get to solidly fuse, at least in the interbody space. I think a lateral and ALIF is a lot easier to get it to kind of heal, at least from an anterior column standpoint. Jeff Fishgren had a study that looked at that TLIFs and push lateral fusions, and it was like 250 patients looking at CT scans, like a really good study. And their push lateral fusion patients healed better and fused more than the TLIF patients. It's really interesting. I am not saying that a TLIF is not a good operation, so I want to make sure I state that. I think it's a great operation, but my personal opinion is I only do it when it's going to, in my opinion, kind of improve or kind of do something else in terms of the goals of surgery for that patient. And this person, for me, it wasn't going to change anything. I think my fusion rate pushed laterally is as good, if not better, than my TLIF fusion. But that's a good question. So,
and last here, if you do a fascectomy for severe foraminal stenosis, are you always placing an inner body? I think we underutilize inner TP fusion, thinking the gap is too large, but with proper technique, it's a great option.
Yeah, that's another great question and good comment. I think I personally, if I'm doing a facetectomy for a really bad foraminal stenosis and to decompress that frame, and I'd say, more often than not, greater than 95% of the time, I'm planning on doing interbody fusion. I routinely do not take both facets in my TLIFs because I want to get a push lateral facet fusion on the contralateral side. If I think I need to take both facets and kind of do more of a posterior column osteotomy, then that changes things, and I will do that bilateral fascectomy. But I would tell you in a routine degen spondy case, I think you can get good lordosis with unilateral fascectomy and a TLIF or a push lateral fusion. And then I do a contralateral facet fusion on the other side. So
yeah, I would say that if you're going to take the facet off, certainly if you're going to take both facets off, I would not rely just on posterior lateral fusion. That's my opinion. I don't know about what you guys think, but when I do a posterior lateral fusion, I get a post-op CT. It's very rare that I see a big chunk of bone intertransverse, and much more common that I see those facets being fused. And so if the facet's not there to be fused, I get very cautious about relying on just an intertransverse fusion if the facet's completely gone.
Yeah, I think it's all the bone, at least for me, it's almost all right underneath that rod, right? So it's in the facet joint, it's medial TP, it's pars, and then kind of medial TP, and just stuff it all right underneath that rod, and it's like a sheet of bone, which is good. I do think that if you take a facet, obviously you're introducing more instability to that maybe initially inherent stable, situation. So that's why I do think that an interbody fusion, TLIF, OLIF, ALIF does improve biomechanical stability of a construct. I just think if you're not taking both facets because you don't need to from a decompression standpoint, you don't necessarily have to. But again, this is just and I know everyone out there knows this, who's listening. This is my opinion, you know, and there's so many different ways to think about this and do this. It's just my opinion. You're going to see more cases that we do it differently, obviously. So.
Yeah, I think one comment, I think the intertransverse process fusion is a little bit of a lost art. I think people that train with Henry Bowman, he did it putting in the screws after his bone graft was out there. So essentially cannulating the screws, doing the decompression, and then really without the screws in there, just packing a boat of bone out there in between the TPs, and then putting in the screws after. And I think that really allows you to pack a robust amount of bone graft back there. Honestly, that's not what I do. I think that's probably the best way to do it. I just find that putting in the screws beforehand is a little bit easier. And I rely similarly on more of the facet fusion than the intertransverse process. And just for, posterity's sake, I stuck some bone graft out there, kind of pulling up with two cobs. But I think really the best way to do it, if you're relying on that intertransverse process, is to put your screws in after your bone graft is packed out there.
Yeah, Dave, that's I think a really good technical point. And actually, when I was in Madison, Wisconsin, that's kind of what Zdeblek would do. So I think that's a good technical point. You have to harvest bone early then. So if you want to do that, what I kind of would recommend people to do is harvest bone early. This way you're kind of, your nursing team, your scrub team can kind of get that bone ready. I personally do my screws first. There's other people who do their decompression first, and I think it's just dealer's choice. But if you are going to kind of do a really good kind of YTP to TP fusion, I'll kind of basically, get my starting point, do my Linky probe, tap, both, kind of, screws at 4 and 5, do corticate, bone graft, and then put the screw in. Because I agree, once for a small incision case, if you're doing a relatively small incision, decompression, fusion, regenerative spondy, you just can't get out there once the screws are in. So. All right, so let's kind of go to a different type of case, and I'm going to have Dave kind of lead this discussion.
Sure, thanks, Jay. So this is a very pleasant lady I saw. She's a 60-year-old female, really progressive symptoms of neurogenic claudication, difficulty with ambulation, no prior surgical history, and I think important to note she did have a history of DVT and PE. Obviously, on her kind of AP and lateral X-rays here, you can see a 2-level. What appears to be a degenerative spondylolisthesis, hard, potentially an isthmic component at 5'1", but maybe tough to tell, and obviously pretty significantly disabled from it. And then here, we have her MRI. It does appear that she reduces a little bit when recumbent, but again, fairly significant stenosis on those mid-axial cuts. And then, when we kind of try and more clearly differentiate the foramina there, I think, 4-5 is obviously pretty squashed down, and then 5-1 as well. Dom, from your perspective, kind of looking at this and after speaking about the, the patient that we saw earlier, is this someone that you think's amenable to a decompression alone, or is this someone that you're thinking, fusion, and if fusion, you think indirect decompression is reasonable, or is this someone that you really want to open up?
Yeah, can you go back to the MRI, Dave? Yeah, so I think that there's significant motion between her lying films and her upright films. So she's a candidate for fusion for a variety of reasons. That's reason number one. Reason number two, she got 2-level spondy. It looks like she's probably got an isthmic spondy at 5'1", given the patency of her canal and the way the x-rays look. So I'd probably fuse that. Lastly, she has severe foraminal stenosis at 4'5", and I just don't know how to decompress that alone, because that's a height problem. You can see on your far pane where you look at that 4'5" frame, that huge disc bulb. It's a height problem, not an A to P problem. It's a low to high problem, and so the only way that you're going to do that is restore height. So yes, I most certainly would fuse her. I think this is a tough case. I think there's a lot of biomechanical stress. She's a lady that's just not built a lot of 4 through S1 lordosis, right? She's just not built that way. So that L4, L3 vertebral body is always going to be well in front of her sacrum. She's never going to be the type of person where you get that back over her sacrum. She's just not built in that way. And so I think there's always going to be a ton of stress at that level. So I know what you did, but I mean, for this one, for me, I would much favor some significant anterior column support just to offload that biomechanical stress and perk it in the back. I don't think you'll have any problem here with indirect decompression.
Jay, when you're thinking TLIF for something like this, and in comparison to the last case, I think it's important as you get into practice and you start appreciating these cases preoperatively. Any thoughts in regards to difficulty of kind of open TLIF in this patient versus the prior one?
Yeah, this is a great case, and it's a tough case, and it's a really tough TLIF, and I'm kind of an open surgeon, so I'm not going to pretend that I could do this MIS. I'd hurt somebody if I tried to do this minimally invasively, right? But if I, you know, I would consider doing this from the back with inner bodies at both levels, for the reasons that Dom was kind of just saying. I do think there's more biomechanical instability in this case than there was the last one, right? I think there's foraminal stenosis, at least at L4, probably at L5 too, right? That I would end up doing kind of, obviously at L5 with the isthmic a gill, but more of a facetectomy, and also try to restore that height of the foramen, and basically with the TLIF, right, you're indirectly decompressing that foramen. I think it's a hard case to do. You're going to have to a fair amount of distraction, to kind of even get in that disc space. So you could distract off the screws, in women, if she's, osteoporotic, I worry about that. You can use a laminar spreader, but the L5 kind of like, isthmic kind of hurts that. So you can't really, distract or spread off that spinous process. This is a tough TLIF. It's a really tough TLIF, I think, to kind of, really try to restore her kind of segmental alignment at L4-5 and L5S1. So this is a case that I would, it's funny, so if the isthmic wasn't there, I wonder, like, if the isthmic wasn't there, would I do something different? I think with this, the grade 2 at 4-5 and the isthmic, for me, this is probably a slam dunk anterior approach, and I don't do a ton of anterior approaches, but I do love an ALIF in this situation, because I just think you're going to get a better fusion rate, you're going to get better indirect decompression, you get better segmental alignment at both levels, so I really like that for this case. If the isthmic wasn't there at 5-1, I wonder what I would do. I may actually consider doing a TLIF from the back, and when I kind of consider saving the 5-1 level for another day, from the front. But for this, in my mind, I think this is a great 2-level ALIF case, at least in my hands. Then the question is, what do you do in the back? Do you perk? Do you do a standalone? I don't think any of us would really do a standalone on this, right? But just too much instability. Do you perk the back or do you open the back? I think I would probably, it would depend on just kind of what it looked like and whether or not I thought I need to do anything else in the back to get the alignment I wanted. So if I had the alignment I wanted after my 2-level ALIF, 4-5 and 5-1, I'd perk it all day long. I think that's a great case. If I didn't, then I would probably consider opening it up, maybe doing a little bit more facet resection stuff, and then compression open, to get the alignment. So that's how I'd think through this case.
Yeah, if you're going to treat this from the, I'm sorry, Dave. Go ahead.
No, I was just going to say, I think, as you continue to practice, you start realizing, boy, that case went smoothly, and you should look back and see, what were the nuances as to why you think it went smoothly, critically evaluate it. And then when cases go tough, you want to say, what was difficult about that? And so for me, I think looking at this case, this is a tough TLIF, and I'm sure, all of you have seen it in fellowship, and the post-op x-rays look great. But if this is, one of your first 50 TLIFs on your own, this is a tough 2-level TLIF. It should be your only probably case that day. You shouldn't have another room going and you're worried about that. It's a tough case. So for me, the concern a little bit was the fact that she had history of DVT and PE, and pretty significant DVT. So, manipulating the great vessels, how important is that? But based on everything kind of, both of you guys said, I was definitely favoring an ALIF from this perspective. And I talk to patients about exactly what you said, Jay, perk versus open, with the understanding that if we're very happy with the alignment and the indirect decompression and the reduction and kind of that increase in posterior height. So if I'm able to reduce them, I'm able to increase that posterior height of essentially the disc space pretty significantly, then I'll just do percutaneous screws. But patients, understand that if that's not the case, we might have to do it open as well.
Did
Yeah, I
you
think Dom, go ahead.
just 2 quick questions. Did you get a pre-op CT, and how sticky did 4-5 look on the pre-op CT? And my second question is for you, Jay. If you're going to treat this all from the back, given her greatest spondy at 4-5, would you make any consideration to going up a level or going into the pelvis? Would you think about that at all for her?
Yeah, that's a good question. It's funny. I was going to actually ask about the CT too, because I think the CT will tell you a lot of information of how mobile you think this is going to be, in terms of kind of, doing the ALS and indirect decompression. I also think it's going to give you a lot of information on the pedicles, these L5 isthmic spondy pedicles for everyone on the call. I don't routinely get CTs on all my fusions because I think it's way too much radiation. I don't think you necessarily need it on a lot of patients, but the isthmic spondies, I get CTs on because they oftentimes have really dysplastic pedicles and kind of the up down, cranial caudal plane. If you look at the axial, they always look huge. You're like, oh wow, that's a big pedicle. Look at me. But then you kind of look at the sagittal, and there's like 3 millimeters of pedicle. So that may change things, right, in terms of kind of how you do this. Particularly if you're like planning on doing a reduction maneuver from the back, right? You need to have good screws into L4 or L5. To kind of actually reduce that if you're doing it from a posterior based approach. So to answer your other question, Dom, yeah, I wouldn't go to L3. I think I would try to put as big and as long of screws as I could into L4, 5, and 1. I don't think there's any kind of, well, I shouldn't say that. I don't think anyone would fault you if you went to the pelvis on this, because you basically have got, you've got someone who's got a pretty significant grade 2 spondy at 4, 5, and 5, 1. If you don't have great S1 screws, sometimes, I try to put bicortical or even kind of that tricortical, right, S1 screw going toward the anterior promontory. But if I didn't love my S1 screws in a case like this, I would go to the pelvis all day long.
Yeah, that's what I figured.
Yeah.
I think,
Just
sorry, Jay, great point about the hypoplastic pedicles. I routinely get CTs, often to assess calcifications in the vessels, anterior osteophytes, just from an exposure standpoint. But that is a critical comment on any isthmic spondy, is a CT to evaluate that L5 pedicle, because there are times where you have to go up to 4 just because that's not amenable to a screw. Two quick questions. One is issue with L5 S1 angle doing an A-lift with symphysis getting in the way. It's a very reasonable question. If I am concerned about it, this lady, I was not. Her scout CT showed that it was amendable, but if I'm worried about it, I will get a supine X-ray in the clinic with a bump under their sacrum in order to evaluate whether or not I can get that angle. And I haven't come across someone where I felt that, I wasn't able to get it. And then the second one is, Dr. Savage, what is your standard interbody for A-lift? Do you still use femoral ring allograft a la Cliff Tribune?
Yeah, thanks, Dave, and thanks, James, for that question. I don't tell Cliff that, but I don't use femoral ring anymore. I think femoral ring is great. I had a few femoral rings break and crack. There's some maybe loose kind of data to support that if you use BMP in a femoral ring, you can get some kind of osteolysis and resorption. But Cliff series is probably the biggest series, and him and Doug Orr, honestly, one of our partners in the Cleveland Clinic, are probably the biggest series of femoral ring allografts for A-lifts, and they've been very happy with them. I personally have gone to using kind of a 3D printed porous metal A-lift cage. I like the biological kind of potentially properties of that implant. Obviously, cost is a real thing. It depends on contracting at your hospital, and that's a big thing, honestly, in terms of kind of how much these things cost. We actually have a relatively good contract with a couple of companies, so we keep our costs down. And I don't think our cage is actually that much more than actually a femoral ring, which is interesting. But James, to answer your question, I've gone away from femoral rings, and I end up using a porous metal. Any other questions from the audience, or I'll show you what Dave did. And I love this, Dave. I mean, I think honestly, it's interesting. Like when you get into practice, you kind of always say, what's the smallest surgery I can do to take care of this problem, right? And then you kind of think about a 2-level A-lift with perch, like, it's a decent sized surgery, right? And you got to have a good access surgeon. That's big, for when everyone gets out into practice, you got to be honest with yourself in terms of the resources you have, right? I mean, so if you've got a really good access surgeon, this is a great operation. If you don't have a good access surgeon, you could hurt people real bad by doing this operation. So I think that's really important to kind of just comment on. But I like this, Dave, in this case, because this is a tough case. It's a tough case to kind of reduce. It's a tough case to get the alignment well. And I think this option gives you the best chance every time to kind of do it right the first time, honestly. So I think this is great.
A couple of points here, Dave. I'm gonna compliment your work also. You put one screw. I know it's shocking. You put one screw in the cage right? It's so you could reduce it from the back if you needed to. So that's a technical point. If you put two screws into the cage, you're not going to be able, because it's going to move as a unit then. So if you have any hope of reducing that spondy, even from threading your caps in when you're perking screws, that cage can't be fixated in both vertebral bodies. So that's just a technical point. So I like what you did there. I think this looks great. The other thing I'd mention too, I do a lot of, I don't forget that instruments don't always belong to one surgery, right? So I use a lot of T-lift instruments in both my ATP surgeries and my A-lifts. So she was pretty collapsed at 4.5. Don't forget spreaders and shavers exist. Okay, so you can stick a spreader or shaver into that 4.5 disc space and spread it open. That'll help you with some of your reduction. Certainly, if you have like a rotatory subluxation, I reduce those through the front often, and you get two shavers in there, turn them in the same direction, take one shaver out and put the cage in juxtaposed to the shaver that you left in to keep it reduced. So don't forget that instruments don't just belong to one surgery. If you need to shave that disc space out, get your T-lift set out.
Yeah, I think those are really good points, Dom. And if you are using a femoral ring, just go back there real quick, because those things will break if you hit them hard. You got to use some sort of instrument to help kind of insert that, kind of a distractor or a slide or something like that, because then it's a much slicker way to do that. Dave, were you able to compress off these perk screws?
I do not routinely, Jay. I think I do exactly what Dom said. If I'm really happy with the reduction anteriorly, I will put screws both up and down to just lock it in place. If I'm trying to get a little more posteriorly, I'll final tighten those S1 screws and try and kind of sequentially reduce them back a little bit more. But I don't believe so. It's rare that I do actually compress in the back for more lordosis.
I mean, it looks great, and honestly, like, you're wondering, like, the 5.1 cage, if you compress, maybe you got a couple more degrees, but it is, that's just being super overcritical because I love you, but honestly, that's the only reason why I say that, but it looks really good. All right, and I knew this was going to happen. It's funny, we have like 6 cases here. We're probably going to get through 3 of them, but let's Dom, let's kind of go through this one, and we can kind of run through it relatively quickly, but I think there's some good
last question, Jay. One, is that 4.5 cage too deep? My goal for these cages is really to get them along that posterior end plate, because I think it really opens them up well. It's interesting. I know this is, not a Cleveland Clinic thing. I do neuromonitoring for these cases, just for the final cage implant. I think sometimes if it's a big reduction, I just want to know that, there's not something that went out, but that's my goal. I do when I perk screw, we do a fluoro spin, and I use navigation. So, always being careful with the cage placement, but really my goal is to get that along that posterior end plate.
Dave, that was the only spot you could put that cage, because it's in the back of L4 and it's all the way in the front of L5. That's a perfect spot for it. There's no other spot to put it. All right, so this is mine. So this is a 59-year-old lady. She's also an employee at the clinic. She's had years of mechanical-based back pain, bilateral leg pain, and she's had all the non-op stuff. So you can see that she's got a pretty significant slip at 4.5, probably graded around a grade 2 slip. AP doesn't demonstrate any sort of rotatory subluxation, asymmetric collapse. She's got obliterated lateral recess, a little chunk of area left in her central canal, and she's still pretty slipped on her MR. On her right side, she's got pretty bad foraminal compression. You can see there. And our left side, I'd say her foraminal compression is not all that bad. So Jay, Dave, what do you guys think, and what are your thoughts here with this nice lady?
Dave, go ahead.
Sure. I think, another classic case that everyone's going to see a bunch, right? This is the case we always like to talk about: big, sexy 3-column osteotomies and T4 to the pelvis and T1 VCR. But this is the case day in and day out that you're going to see in clinic. And I think what's key is really establishing rapport with this patient, understanding their goals of surgery, understanding what it is that they're trying to get back to. As Dom said, if this is a nurse on the floor that's extremely active, that wants to get back to triathlons in 6 months, that's a very different patient than a 75-year-old who's trying to get back to her local bridge game and just kind of wants to have, a pretty sedentary lifestyle. So I think for me, again, all options are on the table. For me, I don't do anterior to the psoas. I think it's a great operation. I just hadn't trained on it. Just looking at this looks like a little bit more difficult of a direct lateral. Obviously, that's where anterior to the psoas would be nice. For me, I'd probably be thinking about a potential TLIF or ALIF with perk screws. But I think any options really on the table.
Yeah, Dave, I agree with you. Great case. Everyone on this call is going to see a ton of these, and I don't think there's one right way to take care of it. I think we would all agree that a decompression alone in this person is probably not the best option, right? So, however you choose to do this, as long as you kind of do it well and achieve those goals of surgery, I think the patient's going to be really happy. You know, I mean, you could do a decompression and push off fusion in this patient. I worry a little bit about alignment, you know, because it looks a little flat at 4-5. You don't want to set them up for kind of, you know, that road of failure if we kind of start fusing people flat. But I think you can argue and do a well, you know, done post-lateral fusion. I think a TLIF, open or MIS is a great option in this person. I think you know, I do a fair amount of direct lateral, not a fair amount, but I do some direct lateral stuff. I think you could do this. The crest may be a little bit in the way, but I think you probably can get to this lateral if you want to. Obviously ATP is a great option. I think ALIF and perk screws is a great option. If you kind of put me on the spot and say, what would you do for this person? I'd probably do an open TLIF on this. It's just kind of what in my hands probably is the best thing for this patient, but you know, I think they're all really good options.
So do you guys worry? I know you said open TLIF, but both of you mentioned ALIF and perk screws. Do you guys worry about indirect decompression here with your level of central stenosis?
Yeah, I do, Dom, honestly, which is why I probably wouldn't do it. You know, I think if you have a good conversation with someone and say, listen, I like the idea of an ALIF here because I think it's going to improve fusion rates. I think it's going to improve segmental lordosis, but there's a small chance we have to make a small incision in your back and, you know, do a decompression. I think that's okay, you know, but in my, you know, kind of my, it's kind of, I can't believe that I'm the oldest person on this panel, right? It's amazing. But in my years of wisdom, I just like to look at the nerve roots and make sure they're decompressed.
Yeah.
I think it's a great point, Tom. I really liked your bit on using some of the TLIF instruments. I think this is a patient that, again, their facets look pretty locked in. I worry about you know, the reduction you get, but I think that if you really take your time, you know, you use those paddle distractors, you really crank open this disc space, I think you're going to free it up and get it loose. And I think that, you know, it would be amenable to an indirect decompression. You just have to be critical and make sure that, you know, you're not kidding yourself. If you don't reduce this, those nerve roots are not going to be decompressed indirectly. And then you are looking at doing an open or maybe a mini open MIS decompression.
All right. Well, I agree with all those points. Why don't we go to what I did, and I can tell you why I did that. So I did anterior to psoas surgery on her and percutaneous or fixation in the back. So we did this at 4-5. Her anatomy was very favorable for it. I did use the TLIF shavers in there, so I rotated them backwards. Every time I rotated them backwards to try to loosen that up and encourage it to move posteriorly. So probably took her from a grade 2 to a grade 1. And got a lot of height out of her. The reason I did this particular surgery for her was I wanted to maximize the amount of lordosis and height I could get given her bone quality, right? So she had a pretty significant slip, and I, you know, probably somewhere in the midline of bone quality. I'm sorry, I apologize. I did get a DEX. I don't remember what her T-score is, but when I get that preoperative X-ray, and the soft tissues and the bones start looking kind of similar, that's just my worry. I try to make sure that I can get a big footprint cage in there just to reduce subsidence, and then I don't really push it when I'm expanding it. I use expandable cages, and they expand both in height and lordosis, so I could sort of try to dial in more lordosis as I'm expanding it. I tend to do these single position. I think whether you flip them or do them single position is just a comfort and dealer's choice. I think this case is a good example. You get lordosis by putting them in a single position. I don't think you need to put them prone to get single position lordosis. I don't think you need to put them prone when I mean to get lordosis. She had very favorable anatomy for this, which made the surgery relatively straightforward. So if we go back to her MR, and you can see on the axial panel, you could drive a truck in there. So whether you want to call this an ATP 4-5 or a lateral based ALIF 4-5, we went in between the vessels and the psoas. The only tricky thing with her is all those black dots on top of her psoas are big venous structures. So you got to be careful when you're going down there not to get a lot of bleeding and to whittle your way around those venous structures and have clips ready and things like that. But you can see that there's a huge anterior window here. So she got a little bit of retraction of her psoas posteriorly enough to get the cage in, and then dial the lordosis and height that we needed. And she did well. She went home pretty quickly after surgery. But I think an open TLIF would have been fine. I've treated many of these open TLIF. You're always like kind of, how do I say this? You're only as good as your last complication. So the week before I did this case, I did a grade 2, 4, 5 TLIF open, and she like got out of bed and fractured her pedicles around her L5 screws, right? So just kind of, I thought, well, maybe I just get a little bit more anterior support in this lady, and there was extenuating circumstances, but nonetheless, I think complications arise with anything. I think ATP surgery in general, you gotta do some before you do some. Okay, so do surgery with somebody that's doing it already. Start with laterals first, so start with trans-psoas surgery first, and get comfortable with accessing the retroperitoneal space and being in the retroperitoneal space, because you will see the ureter, you will see the great vessels. You will be mobilizing the psoas a bit, and I would recommend you proceed with that cautiously. When I started these, I started having them with having an access surgeon in the room, and now I do all these approaches on my own. But that was a long process.
So Dom, you answered one of the questions, which is great. Another question: BMP in these cases, if you use it, what size? Do you use anything else with it, or what are you putting in the cage?
So I use an extra small kit of BMP and then some sort of like putty thereafter. So either like a master graft or a DBM putty to like carry the BMP. I don't think you need anything over an extra small kit. I think the data on ATP surgery is they fuse. Even up to 5 levels has an over like 93% fusion rate. So I don't do 5-level ATP surgery because it's lunacy. But I'll do up to 3 levels at a time with this, and the data is they fuse pretty well. But I do think an extra small BMP is very helpful.
Yeah, I think, it's interesting because with the newer cages, right, with the porous metals, there's definitely probably more biological activity of those cages, right? Ingrowth, on-growth, and the orthopods on the call know that from the total hip and knee world. And so maybe we don't need the biologic as much as we thought we did, particularly with something like Peak. We just don't know the answer to that yet. I mean, I'm still using an extra small kit, like Dom said, when I'm doing my A-lifts or my laterals. This is a great case because I've seen Dom go through his evolution. He was a fellow with us, and I don't think we did any laterals actually when Dom was a fellow. And then I kind of started doing some laterals, and a couple of my partners started doing some direct laterals. And then he has really taken this and has kind of really gotten really good at these and kind of in the safe way, right? And I think that's kind of the most important thing. And this is a great operation. You could see how effective this operation is for this problem. Like I would probably have done an open TLIF on this case, and I could tell you almost, I can guarantee you that I don't think I could have made it look this good with an open TLIF, even if I tried my hardest, which obviously I would have. It's just hard to get that big of a cage, and it's hard to get that much kind of lordosis. I think the fusion rates with these bigger cages are better. So I think this is a great tool to have in your toolbox, so to speak, but you just have to kind of do it in the right way, and a safe way, and learn it. And then also, like Don was saying before, don't turn this into the only thing you do too, right? I think you can really get in trouble in practice if you do that. So for the sake of time, because I want to honor everybody's kind of night, I'm going to just go through these slides really quickly, just to show you that we don't just do post-off fusions or A-lifts and laterals for these patients. There's a 51-year-old female who I saw with severe left leg pain. She's a very busy obstetrician gynecologist at the Cleveland Clinic. She's got these x-rays. She's got a little tiny subtle slip at 4-5. And she basically had a unilateral radiculopathy for this lateral recess stenosis and facet cyst. So in my mind, this is the perfect situation to do a decompression alone, right? So unilateral symptoms with what I'd call stable spondy. I mean, I think that, in my opinion, is a slam dunk for at least a shot at a laminotomy, to kind of excise this facet cyst. And, this obviously is outpatient surgery. She did really well, and she went back to work like 2 weeks later. This is a 47-year-old female with back and severe leg pain. This is one of my own patients. So spondy at 3-4. I think most of us would agree that this is kind of a mobile spondy or quote unquote a real spondy. lateral recess stenosis. This person had pretty significant foraminal stenosis too. So in my mind, rather than doing that post-dural fusion that I did in the first case, I took a facet, I decompressed that foramen. I thought she was a little bit more unstable than the first one, and I ended up doing an open TLIF. Again, lateral, great option for this person. And then finally, this is one of Dave's cases, just to kind of show this real quickly. 7-year-old female, bilateral leg pain again, spondy at 4.5. We could talk all night about this, everybody. With that disc space collapse at 5.1, what do you do about it? My personal opinion is if they're not neurologically symptomatic from that, I completely leave it alone and ignore it. I don't fuse people just because they've got, degenerative disc disease down the bottom level. Be very mindful of the L5 foramen. I think that changes everything, right? So if you got a degen spondy at 4.5 and they're getting their L5 nerve and lateral recess, but they also have severe L5 foraminal stenosis, that's a tricky one because I think a lot of times you have to kind of do more bony work at 5.1 to get that foramen decompressed. 4.5 ALIF per screws looks beautiful. So just to wrap things up, I think decompression alone I know we talked a lot about fusion tonight, but I think decompression alone is a really good option and very specific in certain patients with degenerative spondylolisthesis. I think stable spondies with unilateral radiculopathy, I think it's a great option for that patient. If you think about it, what are we trying to do, right? We're trying to basically give these patients long-term outcomes and minimize the risk of reoperation. The first thing I think all three of us would tell you is that there's no one surgery that's going to basically kind of take your risk of reoperation down to zero, right? This just doesn't exist in spine surgery, right? So just do what you think is right for that patient, given the imaging studies, given the symptoms, given all the other stuff that Dave was talking about before in terms of, activity level, age, bone quality, everything you got to think about. And that's what makes what we do for a living so hard, but also so fun and kind of, we help a lot of people, but all these are really good options. And just always do what you think is going to be best for that person in your hands. What would you do if it was your family member and they came to you to see you? And I think you're really going to, you're going to stay out of trouble and do really, really well. So, with all that said, I want to thank everybody. It's 9 o'clock. So I want to kind of honor everyone's time. Dave, Dom, thank you guys so much. I love you guys. You guys are the best. And I hope everyone who tuned in got something out of this. So, and thanks again to the AO for putting this on.